I started to normalise my eating or working towards that, I guess my biggest fear was just that I couldn't do it, that I would fail at recovery, that I wouldn't be able to eat normally, that I wouldn't have the support there, the willpower or the motivation in myself to recover. So that was probably my biggest fear.
So in undertaking a nutrition assessment of someone who might have an eating disorder, it's really important to follow the main principles that a dietitian would with any nutrition assessment. So really you would be starting off with certainly considering the person's age and who lives with them at home and what their living situation is like, thinking through if they have any medical history that is really relevant, any comorbidities, if they're on any medications, thinking through their social history as well, their work situation and life and surroundings. And then moving through to looking at their weight history. You need to think about the highest weight that they've ever weighed, their lowest weight, whether they're weighing themselves frequently at home, whether they've lost weight recently or changed weight recently. They may have gained weight recently. When did they first start worrying about weight or appearance? And that might lead into other questions around their life history and their relationship with food and weight as well, such as there may be triggering situations that have happened or stressful life events that have occurred that disrupted that relationship with food and eating, or that relationship with their appearance and their weight. It would also be really important to think about the effects that the changes in food or the eating disorder have had on physical and psychological consequences, such as things like their sleep patterns, their mood, their anxiety levels, their ability to concentrate, as well as things such as their heart's functioning, whether they're getting drops in blood pressure and heart rate, if they're having troubles with their bowel functioning, or if they've had changes in menstrual cycle if they're a female. So it's going to be really important to think about all of those factors. You might also look at their family's history, their family's relationship with food, and also body sizes within the family are really important too, for getting a gauge of how the person that you've got in front of you might genetically be predisposed to looking like. Obviously, the dietetic history, the food intake history is going to be really critical as well in the assessment. You're going to be doing a really thorough history of what usual intake is like, and you might also reflect on what intake was like prior to the eating disorder. Certainly looking at fluid intake, alcohol, caffeine, all of those sorts of factors, any allergies that might be present. You might also consider if a person has any fears about foods or particular worries or concerns about particular foods. And of course, you're going to look at eating disorder behaviours as well, such as if there's any history of binge eating, vomiting, laxative use, using other diet pills or spitting out food, and also considering their activity levels and exercise too. So really, whether you're dealing with a paediatric patient, so a child or adolescent, or an adult, you're really going to be considering all of those factors in all of those cases. I guess the key difference for a paediatric patient though is you really need to think about their growth. That's really critical when you're dealing with a child or an adolescent, as they're at the peak growth period during their life. So you want to be particularly thinking about, are they getting enough calcium in to reach their peak bone mass? Have they reached their menarche yet, where they're menstruating regularly? Have they affected or stunted their growth in any way? You can certainly have growth stunting occur in children and adolescents as well. So you want to be certainly thinking about all of those physical factors. But I guess the other really important thing to think about with paediatric cases is the family environment and the family setting, because that's going to play a critical role in how the patient gets better with time. The family is going to be integral to helping that patient get better. And so looking at relationships with food in the home, how meals are prepared in the home, these are all going to be really important when dealing with a child or an adolescent.
I guess I gained trust in my health professionals by having open communication with them. So, and two-way communication, I guess, when they listened to me and really acted on what I was telling them and acted like they were hearing what I was telling them. I guess that was where the trust was built to begin with. And then I guess the longer that I worked with each professional, the more trust I had in them. I think in the first place, I sought referrals from friends and other people that I knew. So I was asking for personal references of the health professionals. So I was going in there with the feeling of sort of already having a little bit of trust, knowing that they'd helped other people that I knew. I saw a nutritionist, I think it was fortnightly I was seeing her to begin with. And then, I was sort of just on my own with her eating plans. But and still now, years later, she provides support, often checks in with me via email. Yeah, that makes a huge difference, yeah.
As a dietitian, when a new patient comes to you that might have a suspected eating disorder, it's really important to make them feel as comfortable as possible and as relaxed as possible in the session with you. So it'll be important to reflect a good sense of understanding and caring and empathy with the patient, and certainly talking to them in a very non-judgmental way is going to be really important. For example, that might come into play when you're weighing the patient. You want to make sure that that they feel okay with that they're not going to be judged critically for whatever that number is that's on the scale. And certainly in a patient that is feeling particularly threatened by being weighed, you might want to put them at ease by saying that this is really just a baseline. It doesn't reflect anything about them at this point in time. It's really just seeing where they're at here and now. And for someone that's really stressed or triggered by the idea of being weighed, it might be helpful to perhaps even blind weigh them and ask them to step on backwards if they're okay with that. In some cases, it might be that you don't even weigh them in that first session. So it's really important to adapt to each person's need and really get a good sense for how they're feeling and settling into the room. That first initial engagement is really critical for ensuring that that patient keeps coming back so that you are able to help them down the track.
The gaining trust was going to be a really interesting and important factor for me to get help. The ability for me to gain trust in that area did really help because I could have those conversations, and because the dietitian that I initially worked with explained why this is going to work for you. Again, explain what we're trying to do here is moving towards a really successful outcome. We're going to work with you and we're going to tweak it because not every body is different, right? But we're going to balance it effectively and we're going to make it sustainable and livable, and you're going to go and do it yourself.
The thing that actually motivated me or made me believe that recovery was possible was when someone said, a dietitian asked me what my day was like and how I felt and the way I ate and that kind of thing, and told her. And she said, I know that you don't look like the girls down the hall, but you are just as sick as them. And if you want to get better, you deserve that treatment. You deserve treatment to recover. And that kind of, it really helped. It was I don't have to push my body to that point, because she can see what's going on in my head and she can see that that's the thing that needs to be helped. And that was kind of the most oddly empowering situation. It was okay, someone understands and accepts what I've said and is validating the fact that there's a problem with that and that they can help me. And it's not about, how much weight you've lost or gained over the past week. It's about how you feel when you see a certain food. The way she talked to me, I felt like she really cared about where I was at, and she really believed that she could help me. It allowed me to to explore what that meant and to to start thinking about things differently.
So when a patient presents to a dietitian for the first time, it's really important to try and assess what the patient wants to get out of the treatment. So thinking about asking them what are the key problems that they are dealing with at the moment, and what are their goals or aims with coming to see you. If it's a young patient that you're dealing with and you've got parents in the room with them or other family members, it might be also addressing the question to them, and then sometimes you might see a discrepancy in the answers as well, which could direct where you're going to go with that patient. Sometimes it will be that if you're dealing with a paediatric patient, they've been brought in by their parents. The parents are particularly worried, but the patient isn't. The patient might be denying that they have an eating disorder or deny that they're having a problem. They might be very angry as well about even being there. And during that time, it's going to be really important to certainly engage the parents first and foremost. The child or adolescent might be resistant to being engaged, and so you really just want to try and be as gentle with them as possible and engaging with them as possible at that time. But it might also be an important moment to introduce some of the risks and dangers that might be associated with the eating disorder to help the young person understand why everyone is worried and concerned. But likewise, it's a time to express that to the parents and family as well, as it's going to be important to treat that patient as quickly as possible. The earlier things are treated, the more likely they will respond to recovery.
So when I was inpatient, I had access to a dietitian. When I was in outpatient, I had access to a dietitian. When I went private, I did not have access to a dietitian. But by that stage anyway, I didn't need a dietitian, but I did need that in the early phases, because if you don't have a dietitian, one, you need to make sure that from a macro and micronutrient perspective, that you are getting it right for your body and your brain to function, but getting enough of those core nutrients, so the macros and the micros that are going to fuel the brain to be able to repair itself, because that's what you're hoping it to do, to have enough of those nutrients again to be able to fuel your body to heal itself, because it's not going to heal by itself.
The dietitian's role in an eating disorders team is really to help the patient to learn to establish a good relationship with food. Usually when a patient is suffering from an eating disorder, they've got a lot of anxiety around food and they've lost touch with how to eat properly, I guess. They're often not able to listen to their hunger and fullness cues. They struggle to eat foods that they previously enjoyed, and so the dietitian's role is really around trying to help that person to learn to eat well, to nourish their mind and body again. But on top of that, I'd say it's also to address any nutritional comorbidities that might be going on, or comorbidities that have impacts on their nutrition. It can impact on their physical health and well-being, such as if they had something like celiac disease or diabetes or allergies, or even other mental health conditions that might impact on their eating. And the dietitian is in a great position to be able to bring all of those things into play when discussing food with the patient. Also, other markers that would be important would be their biochemical markers and perhaps medical markers that they've got from their GP. So for me, when I'm seeing a client, I'll often get them to see their GP or medical professional the day before coming to see me, so that I've got the results of heart rate, blood pressure, any blood test results will have come through by then, and I'll be able to get a better gauge for how things are going.
I had a conversation with a dietitian early on in the phase. I said, I cannot drink a particular thing. I said, because it doesn't react well with me. With me as an individual, it will not react well with me. If you want these people to eat because it's fuel for their brain and their body and things like that, give them stuff that they're actually going to enjoy, and it isn't going to give them bad reactions and things like that. You need to get that positive approach to food again, not negative.
So comorbidities might include things such as diabetes, food allergies, celiac disease. It might be even things such as depression or OCD or trauma history, things such as that can all impact on their relationship with food, what they're doing with food on a day-to-day basis. So the dietitian will then be able to look at the whole picture and help target and problem solve with that patient in a targeted way.
I debate a lot of things in terms of like food choices, gym choices, even clothing choices. Some days, am I choosing it because I like it or because it's safe and comfortable? Am I choosing it because it's helpful to me or because it's a very subtle like detraction from me? And it's quite exhausting to be thinking about that all the time and to be so aware of yourself and everyone else and what other people are doing. It takes a lot of energy.
So when you're dealing with a patient with an eating disorder, a dietitian needs to certainly think about the type of eating disorder presentation that's in front of them. Across the board, it's going to be really important to look at the food intake that the person has. So what's been happening over the time between when you last saw them and now in terms of their food intake each day? Are they getting a regular pattern of intake in? Are they meeting their broad nutrition requirements? Often we're really dealing with the macronutrient intake rather than looking at the finer details, but that's obviously going to differ between patients as well. So when dealing with whether a patient has gained weight or not, it's important to consider different factors that may be impacting on that during the session. So thinking about a patient's fluid intake or output, thinking about changes in their bowel behaviours during that period of time since you've seen them last, and obviously thinking about any changes in their food intake as well is going to be really critical.
I got handed a number of different meal plans, and I will say this about the program that I was part of. It was okay from my perspective because it was a gradual approach to a meal plan. So what it started off was, we're going to get you to start on this level. When we're all happy that you're meeting the needs of that level, we're going to move you up to another level and another level and another level, and so on and so forth. And that enjoyment did come from having that flexibility to choose some options for the meals and things like that. So I like that, and that gave me back a sense of, that's right, you do have choice. So yeah, flexibility, choice, all of that sort of stuff. That was a nice thing to have. It's a nice thing to get back. And I remember walking into a shop with my dad as I was recovering through the whole process and going, I wish I could eat that. And I said to Dad, this is an experience for you, right? I'm going to take you down a shopping centre and I'm going to show you what I'm going through. I don't want you to say anything or do anything. I just want you to understand what I'm going through. And so we walked through a shop. It was just a Woolworths. And we spent 20 minutes in there and bought nothing. But the amount of things that I wanted to buy and eat, I could have filled up a trolley. And his common question was, why? Well, why can't you just pick that up? He goes, mate, I'd eat that. I said, I don't know. I just can't. I can't. I want to. He goes, okay, fair enough. All right, let's go down the next aisle. Tell me about your experience down here. And that was heartbreaking, because I was letting somebody in on that experience as well, and that was really hard. But at the end of it, the best thing that came out of that was Dad then saying, okay, how can I help through this process? Do we want to have an experience once a week? Do we want to have an experience every 2 weeks where it's just you and I, and we do exactly this, but we pick something? Or we go out and do something. That's what we did.
When a person is malnourished, it's really important for them to gain weight so that their body has the opportunity to repair the cells that have been damaged during the malnutrition period. So during malnutrition, the brain is severely starved, bone health is affected, organs are even starting to break down. So there's a lot of depletion throughout the entire body. And during weight gain, those cells are able to be renourished again and cell repair can occur. Sometimes you will get changes in weight that are manipulated by the patient, and that's important to think about as well. If you're over time not seeing the change that you would expect, or there is always a very consistent change that seems a bit unexpected based on what's been happening in the home environment or with their food intake that's been reported by them or someone else, it might be something to think about whether the patient is changing or altering what's happening on the scales because they're worried about seeing changes there. I guess in other cases as well, you might consider, if a patient isn't gaining weight, what do they then need to do to help that weight gain to occur in someone who's underweight. So that might be a discussion then with the patient and or their family and other health professionals in the team possibly as well to help support that person to eat more and in order to gain weight.
So as far as negotiation from an eating disorder perspective, there are definitely times where you will speak to a clinician or whatever, or a dietitian or somebody that's treating you, and try and negotiate your way out of something. And it does absolutely, that happens. So you may have that conversation, and the dietitian will go, well, no, it's your eating disorder that's telling you that you don't like that, and things like that, or it's your eating disorder telling you the way that you should be eating, and things like that. So again, let's look at the outcome. Right, so let's keep this outcome focused. The outcome is to get you medically fit and your brain fueled to continue on with treatment and things like that.
So refeeding syndrome is a severe and potentially fatal medical complication that can occur when there is rapid refeeding in someone who's severely malnourished and has been so for a very long period of time. Refeeding syndrome is when the body has been functioning in a state of fasting gluconeogenesis, and then suddenly food is introduced and it switches to carbohydrate-induced insulin release, which puts a lot of stress on the body's ability to process the carbohydrate, and it can lead to very low levels of phosphate, magnesium and potassium in the person's body, which can lead to potentially fatal consequences if not managed appropriately. I guess traditionally, as most dietitians would be aware, one would look at refeeding as something to be very cautious around, and usually refeeding would be approached very slowly with gradual caloric loads introduced into the person's body with close medical monitoring as they're going along. However, when we look at the recent literature around this, looking at rapid refeeding in many hospitals around the world now, we're actually seeing that there are very low rates of refeeding syndrome if the patients are appropriately managed. So if there's prophylactic phosphate provided and very close medical monitoring, we actually don't see refeeding syndrome in most patients. So if managed appropriately, it can certainly be mitigated. Another concern that dietitians in private practice or outpatient settings might have about refeeding is whether it is a risk in an outpatient setting. Usually it's something that we'd more likely see in an inpatient setting where we have nutrition introduced to the patient at quite a fast or rapid rate. In an outpatient setting where the patient has to introduce the food themselves, it's unlikely that they're going to feed themselves fast enough for that refeeding to be a risk. But certainly it's something to discuss perhaps with a GP and organise for some medical monitoring as an outpatient if you do think that that might be a concern. A dietitian needs to think carefully about when they've reached the limits of their expertise for dealing with a patient with an eating disorder. Certainly if there is a large extent of complexities, long duration of illness or significant comorbidities, a dietitian needs to reflect on their own skill set and think whether they would be better off referring to someone with eating disorder experience. But I think a clear indicator would be if a patient is not responding well to treatment after just a few sessions, then that might be an appropriate time to seek either additional mentoring or clinical supervision or refer on to someone else. So if a dietitian is wanting to look for advice from another dietitian, or if they're wanting to refer on to someone more specialised, they would certainly be worth looking at the Butterfly Foundation, contacting them. They have a database of practitioners that work in the field. The Australian New Zealand Academy for Eating Disorders also has a database of clinicians which is searchable online, and the National Eating Disorders Collaboration also has a search function on there for organisations and groups that work with eating disorders, and any of these avenues would be helpful for them.
Yeah, I think just a health professional could help someone with those fears by, I guess, just referring to a lot of different support services. So, and just supplying the information of what's available, what support is out there. So whether that be actual face-to-face support or online, telephone, I think just referring to those support services and providing the information so that the patient is aware that there is that support.